I'm really very happy to introduce our first speaker, Dr. Lisa Dixon. Dr. Lisa Dixon is a professor at Columbia University, and she is the director of the Center for, sorry, I don't have, So, a Center Director for Prevention, oh, no, sorry. Yeah. So, Dr. Dixon is the director of the Center,
Practice Innovation.
Center for Practice Innovation in New York State Institute. And what is more interesting is Dr. Dixon is in charge of actually starting a first episode program in New York State. And they are going to call this center On Track. There is no psychosis there, basically trying to avoid the stigma that is associated to the words. So please welcome Dr. Dixon.
Good morning, everybody. I think there's a little morning left. Before I start, I want to just say thank you to Dr. Mala and to really this entire community for having me here. As you know, watching the presentation on developing countries, and I think probably most of you know that the United States is a developing country, or perhaps really underdeveloped with respect to first episode and early intervention, and it's really it's almost really an embarrassment. But I think over the last few years, the United States is starting to understand the importance, the moral imperative of reaching out and engaging young people who are experiencing psychosis. And so I'm now have the opportunity to take the lead on such a program in New York State. And this program is the follow-up of one of the RAISE projects, which I'll talk briefly about later on, the RAISE Connection Program. And I would like to start showing you a video which we made with the assistance, or really in partnership with Pat Deegan. I don't know how many of you know Pat, but she's a very prominent, brilliant consumer psychologist, and she worked with us to make a series of recovery videos that we use both in training our staff and also in our direct work with consumers and families.
I was diagnosed with a condition called paranoid schizophrenia, and I'm dealing with it now because I'm taking my medication. I see a psychiatrist and I see a therapist. Now I'm going to school to be a human service worker, and I'm taking it one day at a time. Okay, marijuana. I enjoyed marijuana a lot. I used to smoke it every single day. I used to smoke an ounce a day. And it used to make me feel invincible. I used to thought I was a queen. I used to thought I was God of the air. It was really good, you know? But the thing is, the after effects, it was not good. Because after a while, you know what I mean, when the high went down, I used to get feel different. You know, like the high would just go away and my anger will start to come on. You know what I mean? And then I want more of the high. You know what I mean? So I can be mellow again. The reason why I had to stop, because it was messing with my mind. I was getting paranoid. I thought one day when I saw my boyfriend that he was a devil. I was getting into fights. I stopped taking my medication. I was getting depressed. I was feeling suicidal. I had to start thinking positive so that I can get in the outer world to see my children again. The way I was able to quit smoking was when I was in the hospital. I went to the downstairs meetings where they used to keep religious ceremonies, and I would hear the preachings, and it would inspire me to do well with my life. And then when I came out of the hospital, I continued going to church and living a decent life, you know what I mean? So that's what helped me. Drugs just clogs your mind from doing anything that you want to do. Plus, if you're taking your medication, it even clogs your mind more. It makes you forgetful, it makes you more paranoid. If you're not ready to give it up, think about your circumstances, especially how it's affecting you. If you're feeling paranoid, seeing things, hearing things, thinking how it's affecting you. And think about your life in the future. Do you want to end up this way 10, 15 years down the line? You know, so think about that.
So that was Tina. She wasn't scripted. Those were her words and her language. And I wanted to start with her words because I think she says a lot, and she says it a lot better, frankly, than probably I'm going to say it. Here's a story of hope. Here's a story of recovery. Here's a story of her thinking about her life, and it's also a bit of a story about the power of the world outside of services. In other words, as she told her story, it wasn't necessarily mental health services that inspired her, although obviously it contributed, but it was her interaction with the church that she visited while she was an inpatient. So it's a very complex problem. I was asked to talk about the challenge of treatment of individuals with co-occurring substance abuse and psychotic disorders, a focus on youth and young adults. And I'm going to, as I sort of alluded to, in my career, I have not have not completed a lot of research on First Episode at this point. I'm in the middle of several projects, so I'm not going to be presenting you my own original data, but I will be presenting kind of a story that is guided by my 25 years in mental health services research, now culminating at Columbia, where I'm involved actually much more with implementation of evidence-based practices than with actual research. But in those 25 years of travels, I have covered many services for people with more long-standing chronic illnesses, and so that's what I'll be reflecting on today. So as I said, so first will be what's the problem? The second is lessons from previous research, which I think I suspect many of you here, to which many of you here have contributed. And then I'll conclude with the RAISE Connection program, which is the foundation for On Track New York, the NIMH, one of the NIMH RAISE initiatives. So understanding the problem. Co-occurring substance use, really since the late 80s, we've understood that co-occurring substance use has been a barrier to the recovery of individuals experiencing long-standing mental disorders or more chronic disorders. It's actually my first project as a resident to work with Peter Wyden and Gretchen Haas, adding on a substance use interview to a study that they were doing. And we've learned over the years that co-occurring substance use is associated with increased hospitalization, relapse, treatment dropout, increased positive symptoms, medical problems, including HIV, hepatitis C, homelessness, and though possibly associated with better premorbid functioning. But really, co-occurring substance use is just, associated with a host of problems. Effective treatment for co-occurring substance use requires an integrated approach, stage-based care, and attention to both disorders. And I want to stop here and reflect, because this is going to be very, very important, on what we know about the effectiveness of treatment of co-occurring substance use and mental illness. And I have to tell you that it's very complicated to study and actually to successfully treat co-occurring disorders. It gets very confusing. What are the appropriate outcomes? Are you talking about Are you focusing on the endpoints related to mental illness? Are you focusing on endpoints related to the co-occurring substance use? Are you focusing on more global endpoints that would apply to both? And the other part of this work that's been very, very complicated is that, at least for many years, the research that focused on treatment of co-occurring disorders was really occupied with the issue of integrated care. That is to say, we used to have substance use treated in one program or one clinic and mental illness treated in the other, and in fact, in many places it's still like that. And so much of the early research focused on integrated treatment, so that it was really, the focus was on the process or the organization of care as opposed to the treatment elements within those programs. And so in the end, what I want to put forward is that while in our last round of the schizophrenia patient outcomes research team, we made a recommendation that there was evidence that treatment for co-occurring disorders was effective, I think the evidence is rather slim. And that's, so that the recommendation, which again came from a careful review of the literature, states that individuals who have co-occurring substance use disorders should receive an intervention which includes motivational enhancement, behavioral strategies to promote engagement, relapse prevention, coping skills training, within an integrated system. That recommendation, which we stated could improve substance use outcomes and could improve mental illness symptoms, was a marginal recommendation. And so that what I think we're dealing with is a problem that even amongst individuals with more chronic or long-standing disorders, we don't really have great, compelling data that treatment works, in the short term. And so that's really the backdrop here, and it's sobering, so to speak. In any event, I'm not saying that there's no evidence. What I'm saying is that the variety of research projects that have, interventions that have been tested, maybe they, one of them will reduce psychotic symptoms, one will reduce hospitalization, one will reduce use of substances, but in my view, we don't really have sort of an A+ recommended intervention for co-occurring substance use disorders and mental illness that hits both disorders and improves functioning in a reliable way. So you can see where this is going to go, unfortunately. Okay, what do we know about co-occurring disorders amongst people with early psychosis? And I'm going to be showing you a lot of Canadian EP data. That's what I call it, EPP data, because I think you all in Canada have done some of the best and most systematic work. And so here you see a slide from an early-ish 2007 paper by Addington and Addington, and what it shows you is the rates of alcohol and cannabis misuse, first at program entry, and about 35%, and if you combine the two, so one or the other, the rates are 50%. And so that's the first point I want to make. It's maybe something that everybody here already knows, but we see high rates of substance misuse amongst individuals presenting to early psychosis programs, with the predominant non-alcohol substance being cannabis. That's the first point. The second point that I'm going to make is that within a year, with really nothing fancy, just routine kinds of support, education programs, the rates go down. Cut in half. So that's the second point. The third point that I want to make is that amongst those who continue to use cannabis, or cannabis use is associated with increased positive symptoms. So does the use matter? Yes, it does. Okay, so I'm going to make this point again. I'm going to make this point with data from the early psychosis program from Ontario, London, Ontario. And here again, you see the same kind of pattern. The white bars and the white blocks represent individuals who were diagnosed with substance use at enrollment. The black bars represent the white bars represent individuals who were not diagnosed. The black bars represent individuals who were. And what you see here is their scores on the DAS, which represents amount of substance use over time. And what do you see? And this was, I think, about 14 months later, on average, the follow-up. And you see, as I showed you before, the rates going down. This is 3 months, 6 months, 18 months, with the decline persisting, although not going to zero. So same pattern. Okay, so now, I actually chose studies to represent geographic diversity. I could have shown you, 3 or 4 or 5 more studies, but I didn't want to. I didn't want to belabor the point. But I think what I want you to see is that these studies aren't just from one place, but they're really from multiple sites internationally. So the next question, and I alluded to this, is if we find that amongst people who present, a good chunk, maybe a half, with, I'm going to focus for the most part on cannabis, stop using within the first, and this is where there's some margin of error here, 3 to 12 months stop, there are persistent users, okay? And so then the question is, what is the impact and who are these folks? And so this slide comes from a study that was done in West London, and you have here 3 groups. And you have the same basic pattern of people who came in, and then about half stopped using, and I want you to look at here are people who came in using and stopped using. These are baseline only users. These are persistent users. And these are persistent non-users. And here's mean positive symptom scale, hallucinations and delusions. And what we see here is that the persistent users, these are the people represented by the black bar, have higher psychotic symptom scores than the people who stopped. So I think this is a very, very important phenomenon. People coming in with use, about half stop. Is there a persistent effect of the cannabis use that we see at baseline? And the data would suggest that, in fact, at least for some dimensions, there is not a persistent effect, that these folks who are the baseline only users look pretty much like the persistent non-users. But the persistent users have higher psychotic symptoms than these other group. This is baseline, and this is follow-up. Okay, so we're going to see the same pattern again. Okay, this is from a study in Spanish Basque Country. Again, follow-up study of individuals presenting with first episode psychosis, and you're going to see the same groups. You're going to see the green line represented by people who used and stopped, people with who used but had continued use, and people who never used. 3 groups, same issue. About half the group who came in using stopped using, and this is cannabis. And this is global assessment of functioning. And what you see here, interestingly, and this is over 8 years, is that the people who used and stopped look better than the other 2 groups. Here, I'm going to actually move to this one first. Negative symptoms, same groupings. We have people who used and stopped, never used, and continued use. And what you see here, actually, is the people who continued use having higher negative symptom scores. And actually, the used and stopped and never used group look actually kind of the same. If I go back to this slide, here's positive symptoms, and actually, in this case, all 3 groups look the same. So the major points that I want to make are high use at baseline, immediate or relatively proximal reduction with essentially recovery of whatever problems were caused by the initial use amongst those who stopped using, but then again the persistent using group. So now we have to sort of dig a little bit more deeply into the phenomenon and try to understand what's going on. Now, when I was asked to talk about this, I could have done a whole hour discussion on whether cannabis use is an ideologic, it contributes, it's an ideologic agent to psychosis, and I'm not going to talk about that. I'm sort of, in my implementation role, become much more of a practical person. But I do think this whole notion of sort of the chicken and the egg in the context of individuals with ongoing psychosis and cannabis use is one that's important to explore. And this is a study that was conducted in Brisbane, Australia. And here again, you have a group of people presenting with psychosis and cannabis use. And so these investigators, Hidis and Daw, asked the first question was whether cannabis use contributed to psychotic relapse. And they did a regression survival analysis model and found that even controlling for medication adherence, baseline psychotic symptoms, et cetera, that days of cannabis use predicted psychotic relapse. But then they asked another question. They asked the question of whether psychotic symptom severity increased cannabis relapse, or the likelihood of worsening of cannabis use. And what they found was that it did, that in fact, the higher the psychotic symptoms, the more likely an individual was to have an increased use of cannabis. And one could interpret this as saying, well, this is sort of the self-medication hypothesis. I would sort of be reluctant to necessarily jump to that conclusion. I mean, I think there's a lot of potential explanations for this, including just the idea that someone who's very psychotic may not be able to use their sort of stabilizing skills and maintaining some level of cannabis that they have. It could be that, and we see this in some genetic work, that there's a bit of nihilism. Well, I'm already so bad off. What difference does it make if I use more? But again, I think the notion that, to me, what this is, the way that this is instructive is because it tells us that we really have to kind of get more into the minds and more into maybe perhaps the biology of what's going on here within people who are making these decisions. And I'm not going to, this next slide is from a paper by Dr. Freedy that you'll be hearing about, but I thought it was such a wonderful paper, and he will take you a little bit more into, I think, how individuals who are using cannabis and making choices about medication, how they may think and the trade-offs they may make. But I will just make the overall point that sort of similar to what the previous research that I've already shown you, that ongoing cannabis use is associated with more symptoms. So I'm convinced that, in spite of kind of the good news of the ability and the observation that many people stop, that folks who aren't, we still have to work on. So, and we have a lot more work to do. So now I'm going to shift over to the treatment literature, and it's not terribly extensive in first episode, but again, I think we have to see where we are right now. So here's so we've got this group of persistent users. This was a study by Edwards et al., which is a randomized controlled trial of cannabis-focused intervention for young people with first episode psychosis, and it compared cannabis and psychosis therapy to psychoeducation, and individuals were enrolled sort of at different points in the program, so that reflecting that the awareness of these investigators that people's pattern of cannabis use could change over the course of time in first episode treatment. So they identified people who were using at particular, they identified people for the study when they had been using 4 weeks prior to assessment. And this was conducted at EPIC. The CAP treatment was individually administered. It was cognitive behavioral, had harm minimization, 10 weekly sessions over 3 months, and content phase specific. The PowerPoint, the psychoeducation was really just kind of basic education, PowerPoint sessions. It didn't focus on cannabis per se. And what did they find? They found that there were no group differences, and both groups improved. So the good news is that both groups improved, but it's not getting us any closer to a specific treatment, and so it's sort of, to me, it's again saying that we're in the context of, I think, some of the usual supportive services that we provide, at least as I think in many first episode programs, that's kind of state of the art at this point. Here's another study that was just published by Madigan et al. This was done in Dublin, South County Dublin, and this was a randomized trial, a larger trial, comparing a group psychological intervention to treatment as usual. And here again, we had individuals with psychosis and cannabis dependence evaluated baseline 3 months and 1 year. Weekly sessions consisting of anxiety management, motivational interviewing, and CBT techniques, which had a variety of phases: entry, commitment, goal setting, challenges, relapse prevention, and lifestyle and maintenance. And again, if you can recall what I said, the port treatment recommendation included for substance use treatment for individuals with long-standing disorders, it really met the standard for the evidence base. And the intervention was once per week for 12 weeks with a booster session 6 weeks later. And what did they find? There was really no difference. If we can think about sort of the domains of outcomes, there were no differences on the drug side, cannabis use, no difference in a variety of symptom measures, positive, negative symptoms, depressive symptoms, but improved in quality of life. So, from my standpoint, and again, I've not been in the trenches every day with individuals experiencing their first episode. I've supervised our RAISE team, but in reviewing this literature for the talk, I think it's sort of sobering in terms of what we need to do and where we need to go, and maybe regrouping a little bit around this challenge. And so I'm going to present to you just a few papers that I think facilitate that. This was, I wonder if this was the paper that Max Birchwood was talking about yesterday. This was a wonderful a qualitative study that was done in UK, in which 19 individuals who are being served by the Early Intervention Service, who had misused substances in the 6 months prior to intervention to the service, were interviewed using qualitative methods. And again, I think I've always found that when you're sort of stuck, this is a good place to go to generate hypotheses and to see, if we can tweak existing services. So what they found, there were 4 themes that emerged from this qualitative study. First, theme 1 was the influence of perceived drug norms on behavior. And basically what they found was that sort of 2 main points that I think what Dr. Birchwood was saying yesterday was kind of normal for substance use. One is that folks said they were that using cannabis and using drugs was very normative for their world. And I have 2 children who are, one who's 20 and one who's 22, and I can vouch for the fact that, that in their world, marijuana use, alcohol use is just extremely common, and nothing anybody would bat their eyelash at. I mean, it's just the way it is. The other piece of normative here was that some individuals reported using substances and cannabis to sort of, to be a somewhat alternative, to escape the normal, but in many ways, I think, escaping the normal in kind of a normal way. And so that was their first finding. The second finding related to the comments, many comments made regarding attributions for initial and ongoing drug-taking behavior. And they commented that there were sort of 2 types of attributions: internal attributions, and many people saying that it was their choice, they wanted to use, it was something that they chose to do, and weighing the pros and cons, that it was fun, it gave them friends, and that sort of thing. And then a smaller number talked a little bit about external attributions, that the use was, again, sort of peer pressure due to the influence of others. And here again, I think the takeaway is that in some ways, this is not different than what we might hear from individuals who are not in early psychosis. The third theme related to, I think, some of sort of the change behavior and sort of discussion of why people stopped and what helped them to stop or why they made the decision to stop. And they talked about a key reason for reducing or stopping was a change in their personal life goals, especially an increase in the perceived value of health, disposable income, and close family relationships. And I think, you heard a little bit of that from Tina. You'll hear a little bit more if I have time at the end from one of the other individuals in one of the other videos. And these comments were made more by older individuals. The younger individuals talked a little bit about how if they are to stop, it would require really substantively changing their social environment. And here again, I think that this is not different. I think from individuals with okay, that was my timer. So okay, okay. The fourth point was beliefs about links between mental health and drug use, and here we see that individuals had thought quite a lot about the relationship between their mental illness and substance use, and had sort of come up with some of the same ideas that we've come up with. So, what to take away from this? I think that it tells us several possibilities. One is that we should pursue that many of the treatments that we've developed are really built on some of these themes, and that we should stay the course. And that perhaps also we should look to the non-psychosis world as well for clues to how to treat this problem. And so I want to, before I run out of time, I want to show you a couple of ideas or new ways to think about it. This is a paper that just came out in the American Journal of Psychiatry, which is one of the first effective studies that shows an effective treatment for adolescents with cannabis abuse. These are not young people with psychosis. These are young people just with cannabis dependence. And this is a placebo-controlled trial testing N-acetylcysteine, which is a precursor of cysteine. Basically, it's an antioxidant. And for those of you who follow the literature on causes of psychosis, there's a hypothesis that oxidative stress actually causes psychosis. So we've got this agent, N-acetylcysteine, that actually is being used for marijuana use. That's an antioxidant. And well, maybe we can get two for the price of one here. And also, cysteine affects glutamine regulation, and as well as being potentially helpful in cannabis dependence. There's also a lot of thinking about glutamate in psychosis. So I'm just going to show you the results. This was, again, a study that compared N-acetylcysteine to placebo, adding, in an 8-week trial, adding NAC to contingency management and behavioral education. And what you see here is this is percentage of negative urine cannabinoid tests, the NAC better than placebo. And again, time to first negative urine, and NAC does better than placebo. So the second sort of bit of information that I wanted to think out loud with you about is, we have these persistent users. Who are they? And we have these theories that cannabis may contribute to psychosis, but we know lots of people use cannabis who don't develop psychosis. So how can we sort of look to the literature to push that forward? And I actually am very interested in how individuals with mental illness experience genetic testing. So in some reading I was doing around trying to come up with an ethically ambiguous question to ask of individuals who may get genetic testing, I came upon a couple of studies which I thought were important. And basically, we know that there are many genes that contribute to schizophrenia. They don't necessarily contribute a lot, but many of these genes have polymorphisms. And there have been at least 2 studies that show that individuals who are at high risk for psychosis who have specific polymorphisms of two genes, the AKT gene and the COMT gene. If they have these specific polymorphisms, they're more at risk for developing psychosis with cannabis use. If they don't have those polymorphisms, they don't seem to be at risk. So this is an example of a gene-environment interaction. Again, you have a subgroup of people who are at high risk. If you have the gene, or the specific polymorphism of this gene, you're put at risk. If you don't, you're not. And of course, people don't. So there have been a couple of studies of the AKT gene, AKT1 gene, and the COMT gene. And here again, so are we dealing with subpopulations? Is it possible that the individuals who have this unique vulnerability to the effects of cannabis use, as demonstrated by their increased vulnerability to developing psychosis from cannabis, are they, is there some biological underpinning to the persistent users? I don't know that anybody's looked to see whether persistent users have any of these genetic differences, but I think that in my view and in my clinical experience, the persistent users almost feel like a very different group, with really, really pressured, persistent cannabis use. So I'll conclude this portion by just saying that the misuse of substances, especially cannabis, is common among individuals with recent psychosis. Half or more of individuals misusing substances will stop using with the onset of standard early intervention treatment, which I think is good treatment. The remaining group who misuse persistently are likely to have worse outcomes with respect to positive symptoms and perhaps other outcomes. Effective treatments for the persistent users remain elusive, but I would put forward that at a certain point these folks are no longer early psychosis, and they're now in sort of the challenge of the kind of the rest of the system, and which requires patience, harm reduction, support, and the notion that you never give up and you try to help people sort of make the decisions in their lives that they when they're ready. And that I think that we need a much greater understanding in the early intervention world of the contextual and biological factors that drive substance use. I'm not going to talk about the Raise Connection program other than to say that we're out of the gate in the U.S. in terms of doing some of the early intervention work, and I would love to both collaborate with you all and come back here in a few years and present some of our experience. Thank you.
Thanks a lot. So we can take one question from the audience. Yeah, we have a question there.
Okay, hi. I have a question. It's sort of a two-part question, but I want to know, do you think, is it more efficient for recovery purposes to treat psychosis and substance abuse together than to treat them separately, where a patient might not get relief from psychotic symptoms in a regular rehab and therefore be more prone to relapse? So that's the first part. And the second part is, the people that you showed on your graph who used and stopped using seem to have a better functionality. Okay, could the initial use of cannabis or the use of cannabis have offered some kind of arbitrary medical relief from greater severity of psychotic symptoms?
So your first question related to the wisdom, or do we want to treat both disorders at the same time? And I think that the we came from the world used to be that someone would come to a program in mental health and be told that no, sorry, we can't treat you because you have a substance use problem, and once you get that taken care of, then you can come back. And that person would go to the substance use program, and if they were, maybe, and they would be told, oh, we don't treat you here, okay, because you have a mental illness and we only treat people, So that's an unacceptable world. That's an unacceptable world. And So that's why we talk about integrated treatment. Now, within integrated treatment, I think, this is where, I could just give the platitude, oh, yes, we treat both disorders at the same time. But I think in practice, there are, different sort of subgroups of people. There are people who you literally, there's this complex interplay, they're all over it, you're talking about the effect of one on the other, and it's absolutely essential that they need to be treated at the same time. But then I would just say, but sensibly, with knowledge about each. I believe, again, this is from my clinical experience. It's not from the literature per se. That there are, at least in our first episode cohort, there are maybe a handful. I mean, we have 65 people, so maybe 5 who have such intense cannabis use and drug use. I mean, just very, very, very unrelenting, and honestly, it's very hard to deal with anything else because the impact of the substances on their ability to relate, on their cognition, on their relationships is so overwhelming. It doesn't mean we have to deal with the mental illness, but I think the focus is more on the substance use. But I think for the most part it would be trying sensibly to deal with both conditions together. Your second question, I'll just be very quick. I mean, there was a lore that individuals who use substances, I think in my very first study we found this, had better premorbid functioning than individuals who did not use substances, and the notion was that the kind of motivation, desire, wherewithal, even drug seeking, the pleasure seeking associated with substance use sort of went along with a better premorbid functioning, and that once the substances stop, you'd see that sort of those better prognostic indicators taking over. But I have to say, it's sort of like the DUP literature, the Pathways to Care literature. The literature is so sloppy, and it's not entirely consistent, so that I don't know that one can say with great confidence that this is the case. I mean, I do think that people who use substances tend not to be those very profound negative symptom patients that have the worst prognosis. And so, once you, again, if you can get people to stop substances, then you may see different subtypes. And okay.
Raul, if you have a very quick question.
Actually, I wanted to make a comment with regards to the treatment of psychosis and concurrent substance use. In our program, we primarily emphasize the treatment of psychosis in the early phases of the illness, but keeping in mind that there is a problem with regards to substance use. And the data that you showed, as well as other data, shows that over an 18-month to 3-year period, there is a reduction in the use of cannabis. We recognize this as a problem. We provide the feedback that this is a problem. We have groups where they talk about this as a problem, but we don't intervene in any specific way to treat them for that disorder. But the important thing is that we also provide the feedback that, based on Jim Vanis's work, that at the time of using the substance, they definitely get a relief from it. It is only subsequently that the symptoms increase. I mean, case in point, patient goes out, parties on Saturday nights, comes home, and at 2 o'clock, 3 o'clock in the morning, the parents are all looking after the kid because the kid has got increased psychotic symptoms. But the other interesting point is there is one clinical observation and one research finding. We find that at a 5-year mark, the alcohol use seems to increase. Not as much the cannabis use, but the alcohol use tends to increase at the 5-year mark. But the second clinical observation is that some of these persistent users, after they have been in treatment for about 4 to 5 years, have a sudden change of heart. They just come and say, cannabis doesn't do the same thing for me anymore, and I'm not using it. I mean, the numbers are too small for this to be reflected in a research finding, but clinically, it is just so fascinating. I mean, these are the kids that we've been talking about, the problems of substance abuse, and nothing works, and then one fine day, they come and say, I've stopped it. It doesn't do the same for me.
In fact, that's kind of... Can you come to the mic? Okay, sorry. We see the use of substances going down with age in the non-psychotic population. So it really, it may reflect just kind of a course of substance use.
Yeah. So I think before passing the micro to Dr. Faridi for his presentation, I have two very short remarks. I think there is a very serious epidemic of smoking that we are not talking about it, cigarette smoking. I mean, yes, we talk a lot about cannabis, but the real killer and the major public health problem in psychotic disorder in general, and we see it starting from the beginning, is smoking cigarettes. And I think we need to do something about that, and we need to be cognizant of that. The second point, I think, looking for what are the factors that make some people persistent in their substance abuse. We have published a study, actually, Cliff Cassidy have led that work, and he showed that comorbid ADHD, amazingly, we don't think about it very much, but we found that 25% of our population have comorbid ADHD. And those who have comorbid ADHD, conduct disorder, oppositional disorder, are those who have much harder time to actually disengage from substance abuse. So I think clinically, beyond genetics, clinically, I think we have a factor to be very careful about and that we need to address.